survival than those patients who failed locally. And local control was prognostic for overall survival both on univariate and multivariable analysis. And this is also highlighted in this meta-analysis, which is a very important one that compared induction chemotherapy followed by radiotherapy versus concurrent chemoradiation. And this meta-analysis showed that concurrent chemoradiation provides better local control with no difference in distant metastasis. And this 6% benefit in local control translated into 4.5% overall survival benefit, meaning that if we control locally better, patients they have better outcomes. Obviously, in the pre-IO era. So the question is now, given the fact that most of these patients they fail first in the chest and failing outside, and local control is important for survival, how can we improve local control? And we can, as radiation doctors, the first thing we think to improve, or the first strategy we have to improve local control is to increase the dose. So I am showing here the RTOG 0617, which was a phase 3 randomized clinical trial that had a 2 by 2 design in which patients were randomized to receive 60 gray, the standard radiation dose, versus 74 gray, and were subsequently randomized to receive concurrent cetuximab or placebo. And the trial showed that the increased radiation dose was associated with higher toxicity, and the use of cetuximab was also associated with a very high chance of grade 3 toxicity. The chance of toxicity indeed was grade 3 was 90% in those receiving high dose and cetuximab, and because of the amount of grade 3 toxicity, patients who had dose escalated radiation, they had worse outcomes compared to those treated with the standard regimen. And this, the absence of benefit of dose escalation using this conventional radiation strategy was also shown in this other clinical trial, RTOG 1106, in which patients were randomized to receive concurrent chemoradiation, or in the experimental arm, they started off with chemoreds, they had a PET scan, and they subsequently had a boost guided by PET scan to up to 70 gray. And the trial showed that patients who received higher dose of radiation did not have any benefit in local regional progression or overall survival or progression-free survival, and the toxicity was very similar. So, in other words, it seems that if we want to try to increase the dose, it seems that using conventional fractionation or the standard radiation fractionation is not the best way to do that. And then we have to think about SBRT. We know from our experience for early stage non-small cell lung cancer, stage 1, for example, that SBRT provides better local control than the standard radiation regimen. So, for example, in this phase 3 clinical trial, patients were randomized, stage 1 lung cancer, randomized to receive SBRT versus the standard 66 gray in 33 fractions or 50 gray in 20 fractions. And the local control was better in SBRT, and this translated it into a benefit in overall survival. And if we look well, the chance of local failure in the SBRT group was only 14% versus 31% in the standard radiotherapy arm, with toxicity profile being very similar in both arms. This other trial, a Canadian trial, uh, patients with stage 1 non-small cell lung cancer were randomized to receive SBRT versus hypofractionation, here 6 gray in 15 fractions. And we see that the local control was better with SBRT, but the p-value in this trial was not statistically significant. And event-free survival and overall survival were similar, with no difference in terms of toxicity. So, what we have learned from SBRT to stage 1 lung cancer is that SBRT is better than the standard radiation, and ideally, we should give a very high dose. We should give BD greater than 100, meaning an ablative dose. And when we give ablative doses, local control is better. and this translates into a better survival as well. So, how do we bring all of this information that we have learned from early stage lung cancer to locally advanced non-small cell lung cancer? Well, the first clinical trials to try to incorporate SBRT to stage 3 lung cancer did it by treating these patients with concurrent chemoradiation followed by SBRT as a boost, as additional dose on the top of chemoradiation. And as we can see from some of these studies, this strategy was not a good strategy because we have increased risk of toxicity. We can see here, for example, among 35 patients, some patients developed um, bronchial stricture. We have fatal hemoptysis in 2 patients. Among 12 patients in this trial, I have 1 patient with grade 5 toxicity. And in the last trial, a lot of those limiting toxicity were achieved. So it seems that this strategy may be toxic and maybe is not the best strategy for these patients. So now the strategy has changed, and now the studies are trying to do SBRT to the primary, followed by chemoradiation to the mediastinum, because the most challenging area for us to give SBRT is to the mediastinum, where all the most important structures are located. And we know that SBRT to more peripheral lesions or to the primary can be done safely. So we have, for example, this phase 2 clinical trial in which patients with stage 2 and in stage 3 non-small cell lung cancer are being treated with SBRT to the primary tumor, followed by chemoradiation to the mediastinum, and then these patients were followed, and this phase 2 trial, which treated 61 patients, showed no grade 4, no grade 5 toxicity, and only 5% risk of pneumonitis grade 3, which is what we typically expect when treating patients with stage 3 lung cancer, which means that probably that's a good strategy and seems to be safe. When we look at the outcomes, 1 year progression-free survival for those patients who received durvalumab was 69%, only 26 patients, but it is similar to what was shown in Pacific arm, in Pacific durvalumab arm, 58%, revealing that it seems to be a good strategy from the progression-free survival standpoint, although only 1 year follow-up. And obviously, after seeing these data, we have now the ongoing NRGLU008, which is a very promising clinical trial that is including stage 2 and stage 3 disease, and patients are being randomized to receive SBRT to the primary with an ablative dose greater than 100 gray, followed by chemoradiation standard 60 gray in 2 gray per fraction, followed by maintenance immunotherapy, or the standard arm, which is chemoradiation to everything 60 gray in 2 fractions, followed by immunotherapy, with the primary endpoint being overall survival and progression-free survival. And hopefully, with this data, we'll be able to understand whether there's any benefit from offering SBRT to the primary tumor and whether this is safe enough to implement in clinical practice. And everything I said so far is for those patients who are suitable, for patients who can have standard chemoradiation followed by immunotherapy. And what happens if patients are not suitable for chemo RT, if they can't get chemo RT? So then we have this very interesting clinical trial published 2 years ago and just recently updated at Astro, in which patients who are not candidate for concurrent chemoradiation with stage 3 non-small cell lung cancer, 50 patients were included in the trial, and those patients who were candidate for neoadjuvant chemo, they had 3 cycles of neoadjuvant chemotherapy followed by SBRT to all sites, to the primary and lymph node, followed by durvalumab, or those patients who were not candidate for chemotherapy, they were treated with SBRT alone. And the SBRT in this context was five daily fractions of SBRT, and the doses typically ranged from 40 to 50 gray to the primary, and typically 35 to 40 gray to the lymph nodes. Patients were followed, and here's an example of a patient that was treated with this strategy, and we can see a primary in this case being treated to 45 gray in 5 fractions, the iso dose lines, the radiation dose being very, very conformal to the targets in a way that we try to minimize toxicity by using this SBRT technique. And if we look at the included population, as I said, most patients received 45 gray to the primary and 40 gray to the lymph nodes in 5 fractions. When we look at toxicity, and this is 5-year toxicity, we had no grade 3, 4, or 5 toxicity, no acute and no late grade 3 or plus toxicity. We had grade 1, grade 2 pneumonitis around 30%, esophagitis 26, and acute pneumonitis 32%, showing that is a very safe profile. When you look at the local recurrence free survival in 5 years, we look at 64%, which is very good compared to what I have shown before. And most failures, they happened in the no-fly zone, so they happened close to the most challenging areas to treat. We can see here that predictors of local recurrence were those less than 40 gray and squamous cell carcinoma histology. And we see that most failures of those treated with 35 gray represented in red, and those treated with 40 gray represented in green. And then, as we can see here on the left, 50% of patients treated with 35 gray, they failed, whereas patients treated with 40 gray, they were way more likely to have local control in the long term. And the challenge with treating SBRT to these so-called no-fly zone is because we have here the esophagus, we have the proximal bronchial tree, and we have to protect these areas, and we have to limit the dose that we prescribe, and sometimes we have to accept a lower radiation dose to the lymph nodes to protect these very important areas. We have also our own Sunnybrook experience in treating with SBRT central or ultracentral lung tumors, and in our cohort, most patients had lung cancer. We have some metastases treated in this location, and patients were treated with 5 fraction, most of them treated with 50 or 49 to 50 gray, and we saw that very good chance of local control and very low chance of grade 3 toxicity. We have now ongoing clinical trial, phase 1, phase 2 clinical trial, now open at Sunnybrook, where we are including patients with stage 2 or stage 3 non-small cell lung cancer who are considered inoperable and are not candidate for chemoreds. And these patients are treated or will be treated with 40 to 50 gray in 5 fractions to the primary and 35 to 40 gray to the lymph nodes. Our primary endpoint is toxicity, and secondary endpoint overall survival, local regional control, and distant metastasis. So to conclude, the standard treatment for inoperable stage 3 non-small cell lung cancer is chemoradiation followed by immunotherapy, and this is associated with high rates of intrathoracic relapse, which is the typical first pattern, the first site of failure. There's a strong rationale for improving local control, and dose escalation with SBRT is a potential strategy to improve outcomes. For those patients who are eligible for chemoradiation, the LU008 phase 3 randomized clinical trial is evaluating the safety and efficacy of treating the primary tumor with SBRT, and mediastinal lymph nodes with chemoradiation followed by durvalumab versus the standard treatment, and hopefully this will help with understand whether there's any role for SBRT in this context. And for those patients who are not candidate for chemoradiation, there are small prospective trials suggesting the safety and efficacy of 5-fraction SBRT, and Sunnybrook wants to build on this information by running the ongoing clinical trial, and hopefully we'll be able to show that this is a good strategy for patients who can't get concurrent chemoradiation. Um, Thank you so much for your attention, and I'm happy to take your questions. And just to finish with my question at the beginning, is there any role for SBRT in stage 3 non-small cell lung cancer? Yes, probably, and maybe soon. Hopefully soon.
Great. Thank you, Daniel, for that comprehensive overview. Happy to entertain any questions from the audience.
So thank you, Daniel, for that excellent presentation. I was just trying to get into my head this treatment with chemoradiation that was done through the trial, where they were giving a very intense dose of radiation to the mediastinum and the primary, and how did they manage the overlap? And that's maybe one reason for the increasing toxicity that was seen. But the other point I wanted to bring out is that we've sort of had some experience in giving an SBRT boost for pancreas tumor, where we give chemoradiation to say 45 gray, and then we boost the primary, and that seems to be doable and acceptable toxicity. And I wonder if there was a role to look at that in stage 3, as it were.
Yeah, I think the boost to the pancreas is just the fact that it's more peripheral rather than central located. I think the challenge is with delivering very high doses near to the bronchial tree and esophagus and main vessels, and because some of these toxicities are associated with fistula and stricture and also fatal bleeding. So I think pancreas just because of the peripheral location of the tumor. I think that's why maybe toxicity was not a problem. And and I think the first question relates to I think these cases here. I think uh, I did not go over in detail on the technical point on how they managed to boost and to manage the overlap. What I know is that for this LU008 clinical trial, there was a publication at Practical Radiation Oncology where they are given examples on how to manage the overlap and how to treat the primary with SBRT and try to avoid overlap between the primary and the mediastinum. I think this could be a challenge. And I think they before launching the trial, they published that to try to understand and try to guide treatment using this type of approach. And I think also one point why to boost the primary, because typically primary for stage 3 lung cancer, we have bulky primary tumors, and it's more likely to fail in these bulky tumors. It's more difficult to control the primary than lymph nodes located in the mediastinum. So I think that's why maybe the rationale for boosting to escalate those at the primary rather than escalating in the mediastinum. And we know the safety of giving 60 and 30 with concurrent chemo to the mediastinum. So I think that approach of boosting just a primary with SBRT, being very conformal, using a very conformal SBRT treatment to the primary is a good rationale.
Daniel, I just have one question about um, the other, they're all small studies, I guess, not including this one, but if they're allowing for SBRT to the mediastinum, do they have, and I don't even know if in our own trial did we restrict like the number of nodal stations or like in some way to handle the potential risk of large volumes being treated to the mediastinum? Because I guess in head and neck SBRT, we've kind of, in HN13, we created some rules about that. Did we do that on our own, I guess, for one, and has anyone else done that? Or is it just kind of like just don't do too many nodal stations?
So I have here, I didn't include, but new era SBRT, Let me see if I included here. They reported on how many stations. I think most patients had one, but I think they also included like two stations. I have to find, let me open the paper here. But they reported on the trial how many stations were treated. And I'll just
So I guess they
find
didn't
out here.
necessarily
Yeah.
restrict them though either, right?
No, I think they did not restrict.
I guess they probably just allow people to preferentially choose patients that are have less nodal burden, I guess.
Yes,
Which I
yes,
think we all
yes,
would anyways, but it's I guess we could create some kind of rules for that. But I'm just thinking about that. Anyways,
yes. Because I think if you don't want to be super restrictive, and you can allow the doctor to use its day clinical judgment to decide whether to include
yeah,
or not. Um,
sure.
Multiple lymph node involvement was in the newer SBRT trial, happened in 54% of patients.
Um,
So half of them had
yeah,
multiple lymph node involvement.
right. Okay. Thanks.
Okay, you're welcome.
Is maybe a question and a comment. Like I see Isaac's on the call. Um, how maybe SBRT has posed some challenges or like high dose radiation in terms of surveillance and follow up and distinguishing if it's recurrence or it's fibrosis. When we operate on patients, it's more clear if there's recurrence because if something grows on the staple line, that's clearly cancer. Whereas with radiation, when we follow up with patients, it's sometimes tricky to know if it's a scar, is there cancer growth, and if we're adding that on top of medications, it gets particularly confusing. So I'm just wondering, from the radiologist point of view, like have you guys been encountering that more and more with how we've been doing things?
Yeah, so from a radiology perspective, unfortunately, it's a combination of close scrutiny and just and temporal evolution. Basically, in general, the first year, as you probably know, is extremely tough, and then it's a bit of a gray zone between the first and second year. Typically, we expect post-radiation changes to peak around 12 months and then progressively shrink. Of course, if that's plus or minus a couple months. In general, after first year, when things start to grow, especially focally, that's concerning for recurrence. And then the other thing is a pet probably has some role to play in after first year. Within the first 12 months, it's tricky. I expect FDG avidity due to residual inflammatory changes. Not sure that if that answers your questions.
No, it absolutely does. And you often hear in rounds that we try to debate one or another, but it's all those factors that you mentioned. What's the time frame from when treatment was? With the clinical factors, with the radiographic factors, and often we use PET as something to help guide, but it still doesn't give us a definitive answer always.
Yeah, unfortunately, it's suspicion. It usually, from my personal experience, recurrence is typically picked up in more or less in retrospect after like usually I would say two scans, which basically fail to detect it, and then come the third, and then at some point the change becomes noticeable, and then in retrospect you notice like this bulge has been just very very slowly progressing over time. So unfortunately, really, it's um, uh, I guess the change has to be more the morphological change has to be big enough to detect. I mean, PET would be more ideal, but you can't PET everybody, that with any bit of suspicion. So
Yeah, no, thanks for that. Any other questions from the audience?
I just have a quickie actually, Daniel. Like I saw, that group of that cohort of 50 patients, it had like a 30% rate of pneumonitis.
Oh yeah, it was acute grade 1 2. So here, yeah, just presented at Astro now. So 32% acute grade 1 and grade 2, but late grade 1 and grade 2 probably just some scar in the scar in the CT, but no grade 3 toxicity were seen in this
Yeah,
population.
so you think that's clinical pneumonitis, or you think that's like radiologic pneumonitis? That's a pretty high number if it's a clinical pneumonitis.
Yeah, I think most of it might be just radiographic pneumonitis.
Right.
Yeah,
Okay, thanks.
yeah, you're welcome.
Great. If there's no further questions, I'd like to thank Daniel for giving this overview today, and for all of the industry for the usual support for our ongoing education of these talks, and look forward to seeing everyone next month.
Thank you so much.